Prostate cancer is slow growing, but there are certain situations we want prostate cancer patients to know about, especially if you're in a metastatic state. Things like spinal cord compressions or bone metastasis and pain. And so Dr. Schulz is a third-year medical oncologist and he focuses solely on prostate cancer. And today he's going to discuss these situations. In today's video, we're talking about situations in which you may need to pay more attention to the situation because in prostate cancer, because it's slow growing, a lot of people kind of get used to, oh, I have a slow growing cancer, there's a lot of time. And then another thing is if you've been on, deprivation, androgen deprivation therapy, hormone therapy for quite a long time, you're used to being on that therapy. And as the PSA starts to act a little different, I think sometimes patients wait a little too long before taking action. So before we get into other situations, let's just talk about this hormone therapy situation. Can you explain the context and really what would trigger, a change? What would that PSA look like?
The pace of prostate cancer is so much slower than other cancers. By the time something more worrisome or something that needs more attention more quickly comes up, someone may have been living with the prostate cancer for 10 or 15 or 20 years. And I've noticed a pattern that sometimes that sort of languid, it'll be okay type of attitude, which is very appropriate for most prostate cancer patients, carries over into a situation where a little more attention to let's get this going attitude is really, really needed. And situations where I see this are the men who have been on hormone treatment. Usually it's both first and second generation hormone therapy. And the reason urgency can arise is that simple, quick solutions that are so often available at prostate cancer may have been exhausted. So if people are already on a first and second generation hormonal agent, if they've got spots in multiple areas, particularly in the bones, and these medicines stop working, the PSA starts rising, all of a sudden prostate cancer can start moving pretty quickly. And I've done second opinions in a number of patients who have been seeing other oncologists, and it's sort of, well, we'll get a scan in a few months and we'll start you on some chemotherapy in the by and by. And the pace of disease can really pick up in men that have androgen independence plus bone metastasis. This situation warrants not only implementing treatment right away, because treatment can be effective, whether it's Taxotere or maybe Pluvicto or Lynparza or these next layers of treatment that can stop the cancer, even reverse it. Long delays are just giving the cancer a bigger head start. And this mentality of not wanting to give the cancer a head start is universal in other cancer types. And oftentimes when patients are newly diagnosed, they've got that sort of urgency. And we've been saying, calm down, you've got plenty of time. But I thought it would be good to take a moment and talk about this one subset.
Before I get to my next question, I just wanted to remind you that we're having an in-person conference in September, and it is a great way to get your questions answered by world-renowned experts. You can find out more at pcri.org/conference. Now, if you would like to click that subscribe button, it is a great way to support our channel and stay up to date on the latest videos in prostate cancer. And if you would like to support us as an organization, you can do so at pcri.org/donate. Now back to my conversation with Dr. Schulz. So when we talk about the situation, can we drill down the exact timing? Because I think that a lot of patients, if their doctor does say, well, let's get an MRI or let's do a scan maybe in a month or two, should they really be waiting a month? What level does their PSA need to be? How often should they get their PSA? These are questions we get on Helpline quite a lot.
Usually this sort of situation that I'm concerned about that we're talking about today is a situation where it's obvious that the PSA is jumping up quickly. Perhaps not always the case. There are low PSA producing prostate cancer variants, and so perhaps the appearance of multiple new spots on bones, that would be another signal that there's some time urgency here and that we need to get after it. In the prostate realm with these men with advanced disease, always have a backup plan. And there should be a plan in place that if the existing treatment stops working, people already know what the next step will be and have made arrangements. Sometimes you have to get pharmacy approvals. People are being very delayed in even getting doctor visits. They have an appointment in 6 weeks or 8 weeks. And these time intervals are not appropriate in the type of patient I'm describing today.
I mean, it makes sense because people who are newly diagnosed and they've never been on a hormone therapy, hormone therapy works very effectively against prostate cancer in most cases. Whereas these men have been on hormone therapy for so long, your body gets used to it. You've been on it for a long duration of time. And then I think oftentimes, PSA, they don't understand that PSA rise is actually quite significant, and they really do need to pay attention. And sometimes doctors in this busy world that we have, you can't get appointments quickly. And, so it is important, especially if for men who have been on it for a long time, that they pay attention to those numbers. And I think that some men even kind of get comfortable and it's like, oh, I'll get my PSA checked in, a year or 6 months. And it's like, no, that's why we need to pay attention to make sure that the treatments are still working. And it's especially important with that game plan. So switching to another situation that we see happen every once in a while, thank God it's not that often, but it is quite serious, is when a man has metastases and then he starts to kind of feel numb in his legs. There's a hard time walking. Can you explain what this situation is and really the importance of getting to the emergency room?
Right. So let's talk a little bit briefly about how people react after they've been told they have cancer. All of a sudden you feel every ache and pain in your body. Those aches and pains were always there, but you discarded them and looked past them when you didn't have cancer. But now, could it be the cancer? In most cases, especially men that are responding to treatment, their PSA is going down, they're on hormone treatment or whatever, these pains are just from, these men are 60, 70, 80 years old. They have pains and they have nothing to do with prostate cancer. But there is a scenario that you're alluding to where someone who's been on hormone treatment and the same sort of picture where we've got someone with a rising PSA and the hormone treatment isn't working anymore. If anyone develops new spine pain, I'm not talking about pain anywhere in the back, but right in the center of the spine, there has to be a concern that the cancer could be pushing on the spinal cord. And there's no room for the spinal cord to move away from the tumor if the tumor is pushing on the outside. And so the pressure from the tumor can cut off the blood supply to the spinal cord, and this can lead to paraplegia if it isn't addressed in a timely fashion. So men with hormone resistance, known metastasis, and rising PSAs who develop new bone pain in the spine need to get an MRI and get attention. If the pain is severe, as it is when spinal cord compression occurs, that's an emergency. Even if it's 3 a.m, you have to go down to the hospital, get an MRI of your back, make sure that there isn't a tumor pushing on the spinal cord.
So if you're in that situation where maybe you do go to the doctor, they take the MRI and they say, yes, there is a tumor, what do they do then?
Usually it's emergency radiation and high-dose cortisone. There are situations where they'll do emergency surgery and cut some of the bone away and create space for the cord to be able to breathe and have adequate blood supply. But most of the time they can do rapid radiation in combination with cortisone.
One of the questions we had from a daughter was their father started to feel kind of some numbness in their legs and they took him to the emergency room. Is there the chance that will go away and he can regain, full use, or is that temporary? Is it a temporary loss? Is it a permanent loss?
If it's addressed in a timely fashion, it's completely reversible. It's the people who wait around and see if the pain's going to go away, and then 2 or 3 days later their legs aren't working. In most cases, that will not be reversible.
A couple other cases that come to mind. One of them is urinary retention. I think oftentimes men don't realize that if they do not urinate and eliminate, how dangerous it can be to their health. And they think, oh, it's not a big deal, I haven't peed in a while. It's like, no, it is a big deal. Can you explain what this does to the body and really what's happening in the prostate that's not allowing them to alleviate?
Right. I think sometimes us physicians forget that some of these normal body functions may be overlooked by patients, just as you've said. And it's not usually prostate cancer that causes the loss of flow of urine. It's oftentimes just a big prostate or some inflammation in the prostate, or maybe someone's had recent radiation. The solution is not a very pleasant one, but it works really well. You go to the emergency room, you put a tube in the penis, it's called a catheter, and that relieves the pressure. But your point is that if that urine is allowed to back up for too long, and most men are very uncomfortable when this happens, and that drives them to the emergency room. If that lasts too long, you can develop renal failure, and the kidneys failing can become a really big deal if that goes on too long. The absence of the ability to pass urine needs attention. Usually a catheter will have to be placed while they figure out why this is going on. Can cancer enlarging in the prostate cause that problem? In theory it can. More typically, we would see cancer enlarging in the lymph nodes in the abdominal area and pressing on the tube that goes from the kidneys down to the bladder. That's called the ureter. And you have 2 kidneys, so if you've got pressure on one side, you can continue functioning and overt renal failure is not likely to occur. If you were to have a blockage on both ureters, then you'd be in the same situation where the kidneys would not be able to function.
So what does the timeline look like that would create an emergency? If he's not able to eliminate for a day, is it, 24 hours? Is it 48 hours? Is it 4 hours? What's that look like?
Well, partly it's going to depend on how much fluid people are drinking, because the bladder only has a limited capacity, and it's oftentimes not I'm worried that I haven't urinated. It's that the bladder is so full and the patient is unable to urinate. It's extremely uncomfortable. So I think that's another reason that we as physicians don't always mention this as a concern, because patient discomfort will lead them to go to the emergency room, even without anyone telling them that. But there are some people that lose some sensation and have distended bladder over a period of time. And I'd say the answer to your question is that if someone hasn't urinated for 24 hours, certainly even 12 to 18 hours, then they have to start asking themselves if there's a blockage problem.
So we talked about metastases in the spinal cord, and that being an emergency situation because of the pressure that it can put on the spinal cord. A lot of these men, though, are wondering about other metastases that they may have in other places and in their bones, and they do experience bone pain. And once pain starts to set in, you start to wonder, okay, the cancer is getting more serious. Is there anything I need to do about this? Is that pain meaning that it's, that cancer is messing with something else there? How do men tell between the differences of when it's an emergency situation, when it's not?
Well, making a distinction between cancer pain and other types of pain, it's worthy to talk about that just briefly. Pains from cancer typically are continuous and progressive, not usually located in joints, but in bones. They're not located below the knees or below the elbows. There's really not much cancer that goes to those areas. Distinction between non-cancer pain and other pains, arthritis or who knows, is important. If pain is occurring, we mentioned PSAs going up, scans getting worse, or new bone pain. These are the three things that indicate that the existing treatment is ineffective. So if there is an effective treatment, that's always the first step. And the disappearance of bone pain with the initiation of that treatment is the first sign that the treatment is working. The pain goes away even faster than the PSA declines or before the scans improve. When men have very advanced disease, men may have tried different systemic therapies and those aren't working. There are strategies for controlling pain. In prostate cancer, the use of spot radiation to painful areas of bone is incredibly effective. This has been known about for 30 years. And usually pain will start going away within 5 to 7 days of the initiation of radiation. So pain in any specific spot can almost always be controlled with radiation. Narcotics are effective, but cause constipation and drowsiness. They are not ideal, but effective if necessary. High doses of cortisone have an analgesic effect. So apparently there's an inflammatory component in the pain of these things. And so, as we mentioned before, when people have a spot near the spinal cord, they're put on high doses of cortisone, most commonly a medicine called Decadron. Other analgesics like Aleve, Advil, Motrin, ibuprofen have surprising efficacy against bone pain, probably because of that inflammatory component as part of the pain. And combinations of these things are effective as well. The first issue is to ensure that it is coming from cancer. Second is to think first of a strategy to control cancer everywhere, because if one spot is hurting, there's probably going to be other spots that are going to come up soon. And then thirdly, the different type of analgesic approaches, such as radiation, cortisone, and narcotic or nonsteroidal anti-inflammatory drugs.
When it comes to metastatic prostate cancer, I think oftentimes men don't really know what to expect. And so if you don't know ahead of time, hey, if I feel pain on my spinal cord, I need to speak up quickly, it's not a good situation. So the reason we're filming this video today is we want you to know ahead of time what to expect. And I think oftentimes men don't realize that, yes, if you do feel pain in your spinal cord, you do need to act quickly, speak to a caregiver, make sure you get to an emergency room and get that taken care of. I think a lot of people don't also know that, yes, it can be reversible. I've talked to many caregivers who have found this out, and sometimes it's too late, but sometimes it's not, and they've been able to get them to the physician in a timely fashion. They radiate, they alleviate the spinal cord, and they are able to see that situation reversed. Another thing is that I see that men who experience bone pain because they've been told you have metastatic cancer oftentimes don't realize there are things that you can do to help eliminate that pain and give you some just some help and some help alleviate the situation, even if they're still working on figuring out the treatments that may work for you. I think another thing that's important is to do your research, because even in these situations with maybe more than 5 metastases and you see metastases all over the body, we have seen turnarounds. And so it is important to know what your options are and to know ahead of time. You can do genetic testing for PARP inhibitors, but there are a series of treatments that can be done, including clinical trials. So I would encourage you to watch a series of videos that was done by a doctor named Eugene Kwan from Mayo Clinic, and his expertise is in metastatic prostate cancer, and he has a whole playlist that we're going to link in the comment section below. But it's really educational. It's very helpful to know what your treatments are, and he describes the different combinations of what they can do and even shares some of the case studies where they've seen success. Now, if you need help with your particular case, you can contact our helpline at pcri.org/helpline. These are prostate cancer patients who know they have a wealth of information, and they can help build up your questions and your conversation with your doctors so that when you walk in, even in the shorter amount of time that you have with your physician, you're able to get the best outcomes and really make sure that you know the situation that you're dealing with and also know potential options to bring up with your doctor. Now, please remember, most of all, you are not alone. There is help out there, and even if the situation is serious, please speak up, don't give up, advocate for yourself. It is so important. We care, and we just want you to know that you are a very important person to us. We appreciate you watching this video, and I hope you have a great week.